Hey, welcome back, fellow involuntary ambulance corps. It's John Barr back for another episode. This time we're going to relook at C-spine injuries in light of some new evidence that's come out. As usual, take a moment to look at the disclaimer here. All right, so let's get into it. So why am I revisiting this topic? So this topic has gotten a lot of buzz recently in the EMS community, especially after this review came out in about July of 2025, and it's generated a lot of chatter, so I figure I should cover it here. So this was a review of the literature done by some of my colleagues from the National Association of EMS Physicians, and they revisited C-spine, and I'll show you what they found. So to understand this, we need to look at this kind of the history of how C-spine immobilization came to be. So let's kind of look at that, and that really starts like back in World War II. So Dr. Howlett at that time had written describing saying that excessive movement of patients with vertebral fractures could result in hyperflexion or hyperextension of the neck. So this or this. And they hypothesized that if you moved the spine after an injury and the spinal column was unstable, that could lead to irreversible injury of the spinal cord. And so the initial recommendation was developed at that time to transport patients with spine fractures in the anatomic position and with padding to kind of account for the anatomy. That's sort of the initial inkling that maybe we should be doing this. And then a little while later in the 50s and 60s, there were two case series published, and they suggested that post-injury movement could lead to paralysis. So one of them in 1957, Dr. Rogers published 87 patients treated for C-spine injuries, and of those, 8 of them had delayed neurologic deficits. So neurologic deficits meaning like paralysis, etc. Important to note, this article also included pictures of a C-collar designed by Dr. Rogers, and he claimed that it could have prevented these injuries, so there's a little bit of commercial incentive to promote use of cervical spine collars. And so with that, let's see what happens as we go further. So if we then fast forward to 1971, the addition of the emergency care and transportation of sick and injured, that orange book, that's the one I used when I was in EMT school. So a lot of people were exposed to this book. This is the 1971 version. And in that version, based on relatively limited evidence, they had written the following: carefully splint the injured spine, avoiding abnormal or excessive motion, and be sure that the injured person is properly splinted and transported on a long backboard without bending or twisting in any direction. They also mentioned that if the head of an individual with a broken neck is allowed to move, that could contribute to paralysis or death. Paralysis or death. And when this made it into the textbook, even though the evidence behind it was limited, this basically made cervical spine immobilization the standard of care. And that's what I was taught. That's what many people were taught. And so this is sort of how that got into the textbook, even though the backing of the medical literature was relatively weak. Now, they talked about, well, if you don't do this, there's benefits. Basically, they're saying there's benefits of immobilizing the spine. You could reduce further injury. But I think it's also becoming more clear nowadays that there actually is harm to doing spinal immobilization and increase the patient's pain. Being immobilized on a longboard can lead to restrictions of the chest wall movement, leading to respiratory suppression. It can lead to development of pressure injuries, such as decubitus ulcers, especially in the elderly. And also application of a cervical spine collar to the neck increases the intracranial pressure as it sort of compresses on the vessels in the neck, none of which are good things. So we start in World War II, 50s and 60s, there's some case series, not that great evidence. By 1971, despite that, it gets put into the EMS textbook and becomes standard of care. And then in 2013, the National Association of EMS Physicians, as well as the American College of Surgeons Committee on Trauma, put out a joint statement that said basically utilization of backboards for spinal mobilization should be judicious and only when the benefits outweigh the risks. And so I think this was the first time we're really starting to pump the brakes and say, okay, maybe we shouldn't be throwing everyone on a longboard. maybe there are significant risks and we should weigh that against the benefit. And so this was the first kind of inkling that maybe we shouldn't be doing this as much as we were. And then in 2018, there was another update, this time a joint update from the American College of Surgeons Committee on Trauma, the American College of Emergency Physicians, as well as the National Association of EMS Physicians. And they now we're talking about the new term instead of spinal mobilization, spinal motion restriction. And this basically said that actually we don't need to use a long backboard. We could do this with a scoop, a vacuum splint, ambulance cot, or other device. And that the goal was to minimize unwanted movement. And they continued to advocate for cervical collars as a critical component. And I think this is where most EMS systems are now. They sort of have gotten this update, and many places now have a spinal motion restriction protocol instead of a rigid backboard immobilization that we were doing in the past. And so this kind of, as you can see over time, we're de-escalating from backboarding collar to maybe don't need the backboard, just, a soft stretcher or scoop or something like that, but keep the collar. And now we're going to see how this progresses as we go forward. So that brings us to the 2025 review article that I mentioned at the beginning. So let's look at what they said in that. So in the review article, they set out to answer several questions, and I listed the question here and then summarized what they found. So the first question was, what are the underlying pathophysiological causes of delayed neurologic injury in the setting of trauma? Specifically, they focused on movement, hypoxia or low oxygen, or hypoperfusion or lack of blood flow to the area. And what they found, based on some case series and the other studies that were summarized in this study, and you can look at the full paper if you really want to read in detail, but they essentially found that it seems that hypoperfusion, meaning lack of blood flow, which often occurs in the setting of shock in a severely traumatically injured patient, seems to really more likely be the driver of delayed neurologic injury. We know that if the spinal cord doesn't get enough blood, you get spinal cord injury, and that is bad. Now, when they looked at this in terms of, they looked at the perfusion, they found that hypotensive episodes in the pre-hospital setting lead to worse outcomes. So if you can avoid hypotension in the pre-hospital setting, that's a good thing. So I think that's a pearl you can take away. And they did find some other studies, looked at cord edema, contusions, hematoma, vascular injury. So what I would take from this initial question is that in the setting of a spine injury, it may be that hypoperfusion is the real driver of neurologic injury, not the motion. And it may be that there are other factors such as cord edema, contusions, vascular injury. And so I would say this, it's not clean and clear that movement causes the injury. Rather, this suggests that there are other mechanisms pathophysiologically that could be causing it, particularly hypoperfusion and hypotension. Now, the next question they asked was whether or not the use of a backboard and cervical collar resulted in harms. And they specifically focus on decubitus ulcers, respiratory depression, intracranial pressure, or any direct harm to the nervous system. And as I alluded to before, yes, they did find harm, such as decreased tissue perfusion, higher risk of ulcers. And actually, what was interesting even to me is that the onset was even within minutes, and so that the harms are pretty immediate, enough to make a difference even in the pre-hospital setting. Because in the past, many people had thought, well, if they're just on the backboard while they're in the ambulance, they take it off in the ER, it's not that bad. It's only a short time. But it seems like the injuries can occur actually quite quickly. Another important point, and this was re-emphasized to me when I was in residency on trauma, and I think it rings true, that if you put a C-collar, you can miss a lot of injuries because people never then, again, check underneath it. And so it's a really significant issue. You can miss lacerations to the trachea, to the carotid. You can miss an expanding neck hematoma. And actually, in many studies that inform the EAST guidelines, which is a set of guidelines for care of trauma patients, they found higher mortality, meaning higher death rate, if you put a cervical collar on to someone who has a penetrating traumatic injury. What does penetrating trauma mean? It means gunshots, stab wounds, anything that makes a hole in you. So what I would take from this slide is that it's potentially harmful putting cervical collars on. And so we have to weigh the risk of that harm against any potential benefit. So if we add the previous slide to this slide together, one, it's not clear that restricting motion is the cause of neurologic injury, and two, putting a collar on may actually harm the patient. So then they went after the question, well, okay, so it may not be motion that's the mechanism. Collars probably have harm. Are they effective at preventing delayed neurologic injury? Or are they even effective at immobilizing the spinal column? Maybe we put these on, but don't really immobilize it. And so these studies are a little bit conflicting and it gets confusing. So in one case, they found a small benefit in a subgroup with ISS means injury severity score of greater than 9. So that means people who are pretty severely injured, but no overall benefit. They did note that perfusion could have been the driving effect in that study, which was suggested in previous studies. And whether or not the backboard is effective at preventing motion, it's really unclear. Some studies show that, yeah, it helped. Other studies said actually the patient moved around more and it actually made worse. And in particularly interesting case, so one study looked at the movement at where the neck meets the sternum, so like right over here, and they found that because the ambulance vibrates as the patient's transported, it may actually cause like a seesaw or like fore-aft vibration and worsen movement. And then they also looked at, well, okay, there are some cases where people weren't putting CCOS in backboard. Did they have any delayed neuro injuries? And they did not show any increase. So I would say about this slide, it's not clear that the backboard is effective at all at preventing neurologic injuries. It may actually worsen movement in some cases. And again, there's a lot of confounding with the blood pressure and hypertensive events, which may explain the benefit that was seen in some of the studies here. Now, you might be wondering, are there other factors that may affect the utility of backboards, such as patient anxiety, anatomy, age, environmental conditions? And as you might guess, yes, there are, because a standard board and collar will distort the anatomy of a pediatric patient. Remember, they have different head shape. And also, they noted that for geriatric patients, they seem to have longer time before their C-collar could be cleared. And there are reasons for that I'll skip over for now because they get into a little bit more advanced. But it also showed in the long run, the more you're in a collar, the worse risk of dysphagia, meaning choking on food, and respiratory failure. So yeah, so in the very young and the very old, there are additional risks to cervical collars and backboards. So what do the authors say in their discussion? So the key thing these are some of the key quotes that I put. So one of them, they said, well, maybe the reason why we're not seeing a benefit of this is that whatever injury is there, it was there, right? If you fall, you get a spinal cord injury, the injury happened at the point of impact, and regardless of what you do, collar or not, the injury is there. Now, in the next section, I want to make this clear. They specifically note we cannot rule out the possibility that movement contributes to delayed neurologic deficits. Again, they cannot rule that out. Even though a lot of the studies they found suggested it might be hypertension or something else, they can't exclude it 100%. So it's important to acknowledge that uncertainty. Therefore, they mentioned that they believe it's reasonable to engage in coaching and shared decision making. So what shared decision making means is discussion of the risks and benefits of the C-collar with the patient. And they wanted to do that with the intention to minimize gross movement of the spinal cord as much as possible without use of immobilization devices. They also note that patients will inherently avoid movements that result in pain or other injury. And this rings true to me. Like when I was taught, there's a quote from one of my professors in med school that patients will not voluntarily PIF themselves. So PIF themselves means causing like spinal cord injury. This largely rings true in that patients, if they really have the injury, are not going to move. Now, patients who are unconscious or have altered mental status, that doesn't really apply to them. So what they're basically saying is we can't exclude that movement isn't playing a role here. So we recommend telling the patient not to move and minimize movement as much as possible without immobilization devices. That's what they're arguing for here. So what was the ultimate conclusion they had of the paper? They said, well, despite the historical precedent, there's really no clear literature demonstrating a clear clinical benefit to spinal motion restriction. And in fact, there may be harm. There may be harm to doing cervical collars and backboards. They also question whether or not there's really a mechanism in hypoperfusion and suggest that pre-hospital providers like you guys should focus on management of shock and hypoperfusion, and that's the best thing you can do to minimize delayed neurologic injury. And they recommend considering efforts to reduce use of spinal backboards and cervical collars. They also say that spinal motion restriction should not continue to be the standard of care. Remember, that was established in the 70s, so very interesting that they're coming out and saying that. And I think that's partially what generated a lot of chatter from this paper here. So what's my take on this? Are cervical collars dead in the water here? I don't think we can 100% say that this is a funeral for the C-collar. First and foremost, this is one literature review. You need to follow your local protocol and the instructions of your medical director. That being said, does the paper ring true to me? Probably. I think that it is the right mindset to focus on treating shock and hypoperfusion in these patients. So I would really focus your energy on that. I also think that what the authors say about minimizing gross spinal movement is really important. Whether you do that with the C-collar or you do that by coaching or by holding the patient's head or whatever mechanism you're doing, remember, we can't 100% exclude that movement is not a contributing factor here. So the C-collar isn't dead. You should follow your local protocol. I would say this literature grows, this review here probably de-emphasizes use of the cervical collar, but not 100% eliminate it. At least not yet. So follow your local protocol. I do think it's important to acknowledge that this really digs at whether or not application of C-collar should be the standard of care. So I think this serves to question whether or not that's a standard of care. So follow your local protocol. Understand that treating shock is really important in your trauma patients. Minimize movement as much as you can, and talk to your medical director and your local protocols about whether or not you still want to use a C-collar explicitly. Hope you found this helpful. This area, like I said, has generated a lot of chatter, so feel free to reach out to me with any questions. With that, thank you guys. Stay safe out there. And if you want the reference to the full paper, I have it here. Thanks, guys.